Okay, so history taken in dental practice, I would say is really not so much different from a general practice, general clinical practice. You guys have been trained on how to take history in third year, and you have also been trained, you have been in practice, okay, other than the interruptions of COVID. Fourth year, really, you should have really had a lot of practice. So at least it is expected that the basics of history taking you to know, and you understand why it is important to take history. So there's a saying that the accurate diagnosis of a disease depends on the art of taking case history. That cannot be overemphasized. You do it wrong, it's really very unlikely that you will come up with a correct diagnosis. And even, you know, if you can't do a correct diagnosis, then how can you do correct case management? So the rest will not work. So history is taking the patient's history is the most, it's the heart of practice, basically, if I can say. Yeah. So definition, in terms of definition, case history is a planned professional conversation that enables a patient to communicate his or her feelings, fear, and the sequence of events leading to the problem for which the patient seeks professional assistance to the clinician, so that patient's real or suspected illness and mental attitude of patient can be determined. Yeah, you know, many people suffer illness which may not be real. And also their attitude, you know, the patient's attitude towards care determines the outcome. As such, case history is an important and integral part of treatment. Ideally, case history is taken in a consultation room or a private office. So yeah, patient privacy is really important at all times. Don't forget your ethics. You guys already did ethics, yeah. So don't forget your ethics. Patients' privacy is always needs to be respected at all times, because their history, their information is valuable. A proper prepared case history alone is sufficient to diagnose the disease without examining the patient, most times, except for very rare conditions which may need one to go all the way. But sometimes just the history already gives you an idea what is going on. Then maybe you want to examine just to confirm what your suspicion is. Yeah. And in case of controversy, then that's when you can go to do investigations. So you need to note that eliciting accurate, detailed, and unbiased information from a patient is a skilled task and not simply a matter of recording the patient's responses to a checklist of questions. Yeah, because you must know what to ask. Yeah, if you also don't know what to ask, then you are definitely going to do a wrong job. Yeah, this is where really, every time when I ask you guys, please read, please read. This is the reason you need to read. If you are tired of reading, you can consult, you can ask, you can discuss with colleagues, so that you broaden your knowledge and understanding of the basics. Yeah, so it will come handy when you are taking history, because you need to know what to ask. Yeah, wrong question, wrong answer. That is simple. Avoid interrupting patients when they are telling their history to you. Okay. Yeah. Don't, because when you do that, you are disrupting their thought process, you are frustrating them, so they will not tell you what really is the problem. And as such, being a good listener will greatly help you to establish a good relationship quickly with your patient. You know, success of patient care depends on the quality of your relationship with the patient. So why is case history important? Why is it important to do a good case history? This will help to provide information regarding etiology and establish diagnosis of the oral conditions you are suspecting, and also to reveal any medical problem necessitating precautions, modifications to ensure that dental procedures do not harm the patient and prevent, and also it will help you to prevent emergency situations. Evaluation of other possible undiagnosed problems will also come out of this. Discovery of communicable diseases. It also gives an insight into emotional and psychological factors, and it is also for effective treatment planning. Because when you know the history, you know that this person has ever defaulted or they are allergic to a certain drug, yeah? Or you know that they cannot afford a certain treatment line, or yeah, they have maybe a mental illness. So you factor all those, but how are you supposed to discover those if you don't take good history? Yeah. So history is critical for the care, the ultimate care of the patient. Okay. So, okay, in addition, record maintenance, and also it acts as evidence in legal matters. Yeah. Yeah, you saw the person, what did you find? Did you actually do a good job? Yeah. So the sequence of case recording and evaluation, how do you do it? Broadly, the same plan, just like you would have done in a general medical setting. You have to get the general information, you have to establish the chief complaint, then you go into the history of the present illness or the presenting illness, the previous dental history, the medical history, family history, personal history, general physical exam. Then you go into those other things like the physical exam, and you first do the general, then you do extra and intra-oral examinations. Yeah, you cannot jump into doing extra and intra-oral examination before you do the general physical examination. Yeah. Yeah. So, and then you can come up with a provisional diagnosis, then you can, where there's need for additional investigations, then you can do a final diagnosis. Yeah. Then you can come up with a treatment plan. Just the same. So the joint information, what does the joint information cover? Patient registration number, date of visit in the clinic, the patient's name, their age, their sex, their education, their address, their occupation, their religion. Yeah. I think usually people refer to it as the social demographic what information. Yeah. So if you must always do your best to cover this. Yeah. The medical form usually put enough as their name, age, sex. Though it may mean sometimes if you are doing good job, no, is this a patient? Is this a person at a certain level? Because it will help you to know what is, yeah. If they're particularly admitted, you will want to know what they do. It's always on that form, and their religion. So the chief complaint. This is usually established by asking the patient to describe the problem for which he or she is seeking help or treatment. Yeah, who else? Or if they cannot talk, you will ask their next of kin or the person who has brought it. Then this is recorded in the patient's own words. Don't put words in the patient's mouth, because that would be a distortion. Yeah, it is primarily a statement of the patient's signs and symptoms. It is recorded in chronological order of their appearance and the severity. Yeah, the appearance and severity of the signs and symptoms, the chronology of that is what you record. When did it start? It started last week, then over the weekend, and then it became more severe, and so on and so on. And it was like this, I had a fever, and so on and so on. So why the chief complaint? The chief complaint aids in the diagnosis and treatment planning and should be given the first priority. So common chief complaints will include things like pain, wounds, bad taste, yeah, bleeding from the gums. I think you guys already know these things. Loose teeth, hypersensitivity, burning sensation, recent occlusal problems, delayed tooth eruptions, and so on. Dry mouth, swellings in the mouth, injury, paresthesia and anesthesia, yeah. Irregular teeth, missing teeth, routine dental checkup. Sometimes they just say, oh, I've just come for what? Routine dental checkup. So it's really not a complaint, but it's just what has brought there. Yeah, because you will always ask, why are you here? I have a dry mouth. Why are you here? I've come for routine dental checkup. So that's the presenting what? Complaint. So you want to know the history of the present illness, very critical. So the history is a chronological account of the chief complaint and is associated, and its associated symptoms from the time of onset to the time the history is taken. So from when it started to that time when they are before you, when they are in the clinic or when they're on the ward. Yeah. So everything which is associated. Yeah. And to help you elicit the needed information, some of these questions may be good to guide you. You want to know, when did the problem start? What did you notice first? Okay, that is, when it started, what did you first notice? Did you have any problems or symptoms related to this before? What makes the problem worse or better? Yeah, those factors which worsen it, those factors which relieve the problem. Have any tests been performed before to diagnose this complaint? Have you consulted any other examiner, any other physician, any other dentist for this problem? What have you done to treat this problem? I think we always ask, what medications have you been on, or what was done? Yeah. So in a nutshell, when you have extracted the information in the chief presenting complaint and the history, now you want to summarize it. You know, under the mode of onset, when did it start? How did it start? Cause of onset. What were the associated factors? Duration. Is it just hours? Is it minutes, hours, days, weeks, years? Yeah. You know, there are conditions which can be instant. Yeah. The person was just walking there and fell and has fractured the mandible, and now you are seeing them in A and E. Yeah. So that would be maybe under 1 hour. Or another one could have had a slow growing lesion of the mandible for 3, 4, 5 years. So those are different scenarios. Then you are going to look at progress and the fat pain. Is it increasing, and is there presence of the fat pain? Is it a relapse? Has it ever happened before? Or it is a new scenario? Okay. Has there been any treatments? Is there any negative history? Yeah, which could help you know that I need to take caution. Now, in case of pain, you want to do detailed history of pain, very critical. Now, there is the International Association for the Study of Pain. Yeah, it defines pain as any unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. Yeah, unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. Yeah, because many times what brings patients to our clinic, our hospital, is pain. Most times it is pain. Yeah. So the IASP classifies pain according to certain criteria. So they recommend 5 categories, whereby you are going to look at duration and the severity of this pain, the anatomical location, the body system involved, the cause, temporal characteristics. Yeah, the temporal characteristics will be, is it intermittent or is it constant, and so on and so on. We need to know the following about this pain: the anatomical location, that is the site, origin, and mode of onset, intensity of the pain, nature of pain, progression of pain, duration of pain, and movement of the. And also the localization behavior, effect of functional activity, neurological signs, and the temporal behavior. There are mainly 4 types of pain that can be experienced. One would be superficial. This occurs due to direct irritation of the peripheral nerve endings. Then there can be segmental or deep of the cell, occurs due to irritation of deep structures in the body. Then there can be psychogenic or central. This kind of pain arises from brain due to an emotional or hysterical situation. Yeah, so your oral history now when they talk of pain, now you want to try to localize, where is this pain coming from? Is it a superficial pain? Is it a segmental? Is it a deep or visceral? Is it psychogenic? Some factors which we need to consider in pain in detail, which we have already outlined before. Site of pain. Determining the original site of pain is important. The clinician may ask the patient, where did the pain start? Then origin and mode of onset. you may want to ask the patient, how did the pain start? How did the pain start? Yeah, it will give you already to be giving you ideas what is happening. The origin and mode of onset is important to determine the chronicity of pain, whereby a long continued pain with insidious onset indicates chronic nature of the disease. Whereas a recent onset of pain with sudden impact indicates acute nature. You guys learned about chronic palpitis and the acute palpitis. So you now know that acute palpitis is sudden onset pain, chronic palpitis, long-standing onset pain. The severity, the perception of pain varies in different individuals. Yeah. For example, a mild pain may be severe to others. It was just coming in my mind that, for example, those guys who live in Karamoja, they are very, very hardened. So when they can move through thorns, and even you may think that there are no thorns. But I guess a person who has been living in Kampala, like most of you, even the slightest, tickle, you will be crying, like small babies that, oh, pain, yeah? So pain can be tolerated by some individuals. And the severity of a pain gives an impression of acuteness of the symptoms felt by the patient, thus helping in constituting a proper diagnosis. Yeah, so to continue with some of these factors you need to consider, you want to look at the type of pain. Yeah, there are various types of pain. Most common is vague pain. It's mild, continuous. Example is periodontal pain. Burning pain. This pain usually occurs with the burning sensation, e.g. Reflux. Yeah, this is not reflex. Reflux, esophagitis. Then throbbing pain, type of pressure throbbing sensation. This example is abscess. Yeah, when you see a swelling at the periapical area and the guy is complaining of throbbing pain, then you should start suspecting any abscess. Yeah, a dental abscess, or sometimes we call periapical abscess. Then stabbing pain, sudden, severe, sharp and short-lived pain in acute pulpal pain. So acute pulpitis will be stabbing pain. Throbbing pain, abscess. Stabbing pain, pulpitis, acute pulpitis. Shooting pain, trigeminal neuralgia. Yeah, yeah. So these are very important. When I think these presentations of pain, when you are asking the patient, it will already start giving you an idea of what is happening. Yeah. Then other issues of things like progression of the pain. So you want to ask, how is the pain progressing? Yeah. Then duration. Is it hours? Is it days? Is it months? Is it years? Okay. Then you want to know, is the pain localized or is it radiating? Yeah, this is very important in assessing the oral situation. Yeah. So radiating pain, it is the extension of pain to another site, while the original site is still painful. The radiating pain has the same character as the original pain. And so sometimes that's where we call it referred pain. Yeah, referred pain. Fat pain also is a term used to describe the phenomenon of pain perceived at a site adjacent to or at a distance from the site of an injury's origin. Yeah. Yeah. So this kind of radiating pains in the oral cavity, you'll always experience them. A person will be having acute pulpitis on the maxilla, but you remember those nerves have a similar origin, all of them. Yeah, we discussed that last time. So don't forget. Now, because of that, the patient is going to show for you that they have a painful tooth on the lower jaw. You will look, you will examine it, but there will be no single tooth which actually exhibits the pain when you percuss, because you will first inspect, yeah, with your bare eyes, you will not see any cavity. You will use the probe, you will not discover any cavity. You are going to percuss all the teeth in the lower jaw, there will be nothing, no evidence of acute pain. And then when you turn up to the maxilla, you will see a cavitated tooth and just a slight touch on it. The patient is going to jump up and kick you down. So then that's where the pain was all after all coming from. Yeah, so in the oral cavity, this is very, very common. Yeah, so yeah, sometimes pain, somebody will tell you I have toothache, but what is the cause of that toothache? It is the sinus. So the pain is coming from the sinus. Yeah, the maxillary sinus. So there are many instances when you are going to, yeah. So sometimes the pain of the tooth is referred to the ear. Yeah. So those are the things. And you as a clinician, now you need to study more about these things. How are those teeth referred, and what could be because there can be a cavity, then the person will complain of pain in the ear. Yeah. There can be a cavity in the maxilla, they will say I have pain in the lower jaw. Yeah. So this is practical. As you are going to be practicing a lot, you will find patients who will be presenting with this kind of what? Yeah, problems. You also want to know the precipitating or aggravating factors of that pain. What worsens it or what relieves it? Yeah. So examples, the pain of cracked tooth syndrome occurs when the patient relieves the occlusal pressure. So when they move, when they open their mouth, they will feel pain, yeah? But when they keep the teeth in the occlusal position, then there is no problem, yeah. Then the relieving factors which reduce the severity or frequency of pain. Yeah, example, in chronic pulpitis, sometimes when you apply a cold pad, then it can be relieved. So you also want to know about the associated symptoms. Pain may occur along with nausea, vomiting, sweating, flushing, yeah, and increase in pulse rate. Yeah. So now when you are finished with the pain, you want to look at other things, for example, swelling. Yeah, in terms of swelling, you want to see the anatomical location. Where is this swelling? Is it in the floor of the mouth? Is it below the mandibular? Is it in the vestibule? Where is this swelling? Is it on the palate? Where? Is it on the lips, the cheek? Yeah, you guys already know the anatomy. So I'm just challenging you. The swelling will be where the infection is coming from, right? So duration, how long has this swelling been? Is it 1 day? Is it instant? Has it just happened in the past 1 hour? The symptoms, yeah, pulsating, is it painful? Is it not painful? If it's painful, is it throbbing? Yes, no, yeah, yeah. So yeah, duration, mode of onset, how did it start? How the symptoms, those are just some of the questions I've asked. The progress of swelling, is it increasing very rapidly, slowly? Yeah. Is it, what are the other associated features of this swelling? Yeah. What are the other changes which have happened since the swelling came up? Has it formed a sinus? Is it indurated? How is it presenting this swelling? Yeah. Has it impaired any functions? Is it a recurrence of a swelling? Was it there before it disappeared and it has come back? You want to know all those. Yeah. So in terms of duration, you want to ask, when was the swelling first noticed? Yeah. So because swellings which are painful and of shorter duration are mostly inflammatory, so they are acute. Those with the longer duration and without pain are chronic. So the example of chronic one would be periapical abscess. So how did it start? Yeah, the mode of onset. You want to ask, how did the swelling start? The history of any injury or trauma or any inflammation? Yeah, or it just started de novo. Then progression, you want to ask, has the swelling changed in size since it was first noticed? Because benign growths such as bony swellings grow in size very, very slowly and may remain static for a long period of time. If the swelling decreases in size, this suggests a swelling of an inflammatory origin. So the site. So where did it start? So you want to assess the site where this swelling started. Yeah. So you also want to look at the other symptoms. For example, pain, fever, difficulty in swallowing, difficulty in respiration, disfigurement, bleeding, or pus discharge. Yeah. So this is going to give you an idea. Yeah. So you find a swelling of the involving the whole floor of the mouth extending to the root of the neck. It's very painful. The person is really having fever and they're having difficulty swallowing and so on. Yeah. And they're having even trismus. Then you are likely going to suspect something like Ludwig's angina. Yeah. So, is it recurrent? Many swellings do recur after removal of the tissue, indicating the presence of precipitating factor. The example is a ranula. Okay, ranulas are these sublingual cysts. Yeah, they are sublingual cysts. They happen to be in the duct, the saliva duct in the sublingual area. So they bulge up and they become a ranula. When you don't remove them well, sometimes they recur. So, because you guys are studying dental health, there's what we call dental hypersensitivity. Because the patient, that may be all what they're presenting to you with. My teeth are sensitive. That is my complaint. Yeah. So if this many times can be caused by exposure of the dentinal tubules. I think I've already talked to you about this in some previous presentation. And the teeth could have undergone a treason, abrasion, erosion, and so on. Then there could have been gingival recession. Yeah. You know, when the gingiva is recessed, the cementum is going to be exposed. It's likely going to resorb and expose the root where the dentine is direct in contact with the oral environment. And that is going to create hypersensitivity. And also sometimes when they do periodontal surgery or when you do root planing, yeah, because when you do root planing, then you may lose some cementum, and then you end up exposing some of the dentine below it. And the patients will often tell you that the onset was maybe sudden, okay, sock-like sensations in response to cold or hot, yeah, cold or hot stuff, maybe sweet things, sour substances, or when they are touched. Yeah, you touch the root of that tooth, it is sensitive. You touch the crown, the occlusal surface, it is sensitive. Yeah, so that becomes hypersensitivity. What about bleeding from the gums? They will report a problem of chronic or recurrent bleeding. This happens, I can assure you. I will say when I'm brushing, I find my mouth is bleeding. Doctor, what can I do? Yeah, and that is what will bring them to you. Yeah. When I'm brushing, even when I've been eating, maybe I was chewing my sugar cane or I was eating maybe my cassava, raw cassava, I saw a lot of blood. So you want to know how long has this bleeding been? And you also want to know when it bleeds, how long does it bleed? Does it bleed a lot or it bleeds little and stops? And you want to know how easy is it that it bleeds whenever something touches, okay? And it's some of the associated symptoms. What are the associated symptoms? Is there pain? You remember dull pain? We said it was periodontitis. Then is there sensitivity? Okay. So you will now be able to make your judgment. You examine, of course. You don't usually make a diagnosis before you have finished the examination. So you will examine, and then when you see what is happening to the gingiva, then you can say, okay, this may be chronic gingival inflammation or chronic gingivitis. So, in fact, acute bleeding, this will be caused by injury or can occur spontaneously in acute gingival disease. Then there's acute necrotizing ulcerative gingivitis. I think Dr. Quizra talked to you about this. Yeah. of course, that is going to cause, because the gum is flabby and ulcerated, because there's a lot of infiltrates, yeah, the immune response, yeah, creates the gums to become so flabby and a lot of blood. And so it can really bleed easily, yeah, and of course it will be painful, yeah. Sometimes gingival bleeding may be associated with systemic changes, which will include things like hemorrhagic disorders, yeah, platelet disorder, platelet disorders, hypoproteinemia, yeah, coagulation deficiencies, deficiency of platelet, thromboplastic factors, also excessive intake of drugs. You know, for example, aspirin, when you take a lot of aspirin, bleeding becomes easy. Let me connect my computer to the power. The battery is running down, just a minute. Yes. Yes. So drugs like aspirin and anticoagulants may easily, when somebody gets the slightest trauma, you can find them bleeding just like that. Okay. Away from bleeding gums, now dry mouth, which we also can call xerostomia, can be a presenting issue. The patient will say, I have dry mouth, I have dry mouth. If you have never experienced it, now for you, you will take it for granted. But for the patient, they are really dying. Yeah. And the dry mouth or xerostomia is a subjective feeling of oral dryness. And it is a symptom, not a diagnosis or a disease. So let's make it clear. Xerostomia is not a disease, but it is what? A symptom. It's not a, it's a symptom. So what are some of the likely causes of xerostomia or dry mouth? They can be developmental, okay? So maybe due to a salivary gland, hypoplasia, due to drugs like antidepressants, atropine, and so on. Yeah, you guys will be prescribing for your patients drugs, but you remember, maybe if you already know in advance that it is going to cause dry mouth, encourage them to take plenty of fluids. Don't just prescribe the drug and you get the patient to go and suffer. Yeah, it can be due to radiation therapy. Yeah, if you have ever seen, I don't know, because you guys have not been so much in the clinic, head and neck radiation therapy is usually troublesome. It's troublesome. It burns the soft tissue and so on. And so sometimes, yeah, even the vasculature and so on. And the result, sometimes a person can end up with a dry mouth. Also, of course, oncologic chemotherapy, infections, yeah, infections and inflammatory conditions like parotitis, mumps, yeah. Then benign or malignant tumors of the salivary glands can also do that. Yeah, you know that you need the salivary glands to secrete the saliva to wet the oral mucosa. So if the glands have been affected, if they're inflamed or they have tumors, then you are likely to get what? Dry mouth. So dry mouth itself is not a diagnosis, but it is a symptom of something happening elsewhere. There can also be other factors like psychological factors. Yeah, person is just too much stressed. Malnutrition, yes. Yeah, anorexia, bulimia, dehydration. So a person who is also not drinking enough water will have the experience. Then there can be idiopathic disorders. Don't know the cause. Yeah, alcoholism, smoking, caffeine. Caffeine, yes. There can be due to other systemic diseases like Sjogren's syndrome. Yeah. So you will get your patient with Sjogren's syndrome, then they are likely to have xerostomia. Then granulomatous diseases, yeah, like sarcoidosis, TB, and so on. Then they can also be due to graft versus host disease. Then there's the cystic fibrosis and Bell's palsy. So the causes can be really many. So it is just a symptom of an underlying cause. So when you see your patient now in the clinic complaining of dry mouth, then find out what is causing this dry mouth. So taking the history becomes very, very critical. Yes, dry mouth can be due to, yeah, as I said, systemic diseases like diabetes also, amyloidosis, HIV, thyroid disease, late-stage liver disease, and also patients who are on hemodialysis, yeah, in end-stage liver failure. Who is the one who is putting the audio on? We're about to finish, so don't be tired. I know last time somebody warned me that we must not teach too long. So now I have to be very careful. So, yes. Other than dry mouth, a person can also experience what we call burning sensation. Burning sensation of the mouth. It's different from dry mouth, it's different from xerostomia. So burning sensation, it happens. This may accompany inflammatory ulcerative disease of the oral mucosa. But this term should be reserved for describing oral burning that has no detectable cause. That has no detectable cause. So some causes can be stomatitis, ulcers, infections, e.g. candidiasis, or what we call candidosis. Yeah. I think now these days you guys don't see candidosis commonly, but in the olden days when there was AIDS, candidosis was really, really common. Particularly if a person had chronic candidosis, yeah, they will actually experience a lot of burning sensation. Then, of course, due to dry mouth, if we have xerostomia resulting from whatever cause, like a salivary gland hypofunction, then you will experience that burning sensation. Mucosal disorders, like what we call geographic tongue, lichen planus, Yeah. Now I'm going to challenge you guys. You need to, because I'm sure I will never taught you about a geographic tongue. By the way, this is a very common challenge which we always see in the clinic. Yeah, where patients will present with kind of grooved mucosa of the tongue, of the dorsum of the tongue, and yeah, I leave it to you. You can check, do Google search, just ask Uncle Google what geographic tongue is, and you actually need to see how it looks like and what it presents with, because you will get many patients who will come with the complaints. Yeah, sometimes maybe they just suffer maybe some vitamin deficiency and so on, and yet you can manage those things. You don't need to congest the dental clinic when you can handle simple things like the geographic tongue. Then, of course, patients with lichen planus, very difficult to manage, but yeah, so those can also present with burning sensation. Then trauma to all mucosa, for example, poorly fitting dentures. Yeah, people use dentures chronically. A poorly fitting denture will be rocking when a person is chewing, and it can irritate the mucosa. Then esophageal reflux disease. Yeah, so this is a problem, that is now acid coming from the gastric area, and it's of course, how acid tastes. Yeah, when you regurgitate, that's when you will know. Yeah, it causes that terrible burning feeling, acidic taste in the mouth. So there can be other causes like systemic causes, vitamin B12, folate, iron deficiencies, yeah, and medications like the SCE inhibitors, some of them. Then other systemic causes like the immunologically mediated diseases like Sjogren's disease. You remember Sjogren's disease also will cause dry mouth. Dry mouth causes results into what? Burning sensation. So it's just a cascade, if I can say. Then the burning sensation can be psychogenic due to anxiety, depression, fear, okay, psychosocial stress, diabetes, yeah. Diabetes, it really attacks every part of the body. Menopause and hormonal imbalances. Okay, away from burning mouth, which of course now the kind of questions. When did it start? How does it present? And so that's why I'm just going through this to help you to have the questions when you are taking your history. The patient tells you have burning mouth. So you say, when did it start? How does it present? What makes it worse? Yeah. Maybe the person doesn't drink enough water. And then you now know what to do. Yeah. Yes. They're complaining about their loose teeth or tooth mobility. Again, to just summarize for you some of the causes of tooth mobility, loss of tooth support, maybe they have periodontal disease, yeah, trauma. Of course, you want to know, were you in a fight? Did you fall, or did you bite something hard? Yeah. The teeth, many things can damage them. You know that trauma. I think we discussed this in the previous lecture. Yeah, it can be from a fight. It can be maybe they're biting. Some people like going to enjoy what they call past leaders. They bite a bone, then the tooth is there loose. Yeah. Yeah, that's trauma from occlusion. Then abnormal occlusal habits like bruxism, cleansing. I think you studied this with Dr. Quizra. And then also hypofunction, when the teeth are not properly used, they are going to become, you know, the law of disuse, which you learned long time ago. That's going to happen. Then extension of inflammation from the gingival or per apex into the periodontal ligament results in changes that increase mobility. So, yeah, so then also sometimes maybe they have undergone periodontal surgery. Then maybe they are pregnant. So if they are women, you can want to know, are they pregnant? Yeah. So also they're associated with the menstrual cycle, also use of contraceptive pills. Maybe they have infection, osteomyelitis, yeah, of the alveolar bone, or cysts. So do they have a swelling? Yeah. Did they get trauma? Did they get an infection which was affected? Do they have pain? So I'm just highlighting these things. So halitosis, yes, halitosis is quite common. So sometimes patients just come because of halitosis. Halitosis is bad breath. Yeah, it's bad breath. So the origin may be oral. For example, poor oral hygiene, guys who don't want to brush their teeth, or retention of odoriferous food particles. You know, like people who like eating a lot of spicy foods, like the Indians. I know some of you are Indians, so, but I'm not accusing you of eating spicy foods, but it's okay. So, artificial dangers, acute necrotizing ulcerative gingivitis, pericoronitis. I don't know if Dr. Quizza talked to you about pericoronitis. Pericoronitis is the inflammation of the pericoronial flap. It's the what you call maybe also gingiva of the last molars, you know. Yeah, the last molars behind. Yeah, that's the pericoronial flap. So it is notorious because food impacts there in between the tooth and that space, and can always become inflamed. Yeah, so abscesses, dehydration. Yes, when people are dehydrated, they will have bad breath. Then ulcerations in the oral cavity. Yeah. Then hyposalivation, yeah, xerostomia, bone disease, you know. For example, one of the things I'm going to try to mention to you next week is dry sockets. Yeah, dry sockets, osteomyelitis, osteonecrosis. Yeah, osteonecrosis maybe post radiation therapy. Yeah, malignancy is, you know, malignancy. You have maybe squamous cell carcinoma. It's definitely going to smell bad. Every malignancy which is in the mouth will always smell bad. Kaposi sarcoma, whatever, they will always smell bad. Smoker's breath, healing oral wounds, chronic periodontitis with pocket formations. Yeah, pocket, you know, there's going to be accumulation of debris there, and which is going to ferment, and it's going to smell bad. Okay, so I'm going to end with this slide, I think. Yeah, I'm going to end up with this slide. Yeah, so that next week we can now continue with that. extra oral conditions that can contribute to presence of the halitosis. They are not necessarily intraoral, but extraoral, will include sinusitis and other bacterial infections, dry nasal mucosa, blocked nose, which can cause mouth breathing. Yes. Tonsillitis or tonsils, tons. I think you guys have studied this in ENT because you told me that you are studying ENT. So you should ask about tonsils, tons tomorrow when they teach you about tonsillitis. Then various carcinomas, yeah, head and neck carcinoma, yeah, in the pharynx, in the other parts, esophageal, yes. It's definitely going to smell bad. Infections of the respiratory tract, such as bronchitis, pneumonia, bronchitis, all of that's going to smell bad. So you may think that the person doesn't have good oral hygiene, but then if you actually assess and they have good oral hygiene, then go for the other things. Do they have pain in the chest? Is there a lump in the, esophagus? Is the nose okay? Yeah. Alcoholic breath, yes. Have they been taking nguli? Some of you people are spoiled. You also take nguli, so that can also smell bad. Then uremic breath of kidney dysfunction, acetone of diabetes, and so on and so on. Yeah. So this it is a lot, yeah, but you can always narrow depending on the initial history the person has told you. So why all this? It is to help you diversify, because then the person tells you maybe their presenting complaint can be halitosis. Oh, then you can start thinking, asking the right questions. Yeah. Maybe they are complaining of what? Dry mouth. I have dry mouth. Now you know. Do you drink water? Do you what? Maybe my teeth are loose. That's the problem. So, did you fall? Did you fight? Did you get an infection? And so on and so on. So you know what to ask. And so I'm going to stop with the presentation here. The remaining part, I'm going to present first in our next lecture on Monday, and then I will finish. We shall have to finish on Monday. I will now finish with just highlights of extractions. So I want us to understand, why do we do extractions? Maybe some basics of how to be considered, yeah, when we do extractions, yeah. So that when you see a patient, you are able to advise, or where possible, when you can offer support, you can offer. Yeah. So at this moment, let me check in the chat room there. Oh, there are rockets there. Why are there many rockets? It's like missiles, it's like we are in Afghanistan with the Taliban. Oh yeah, people. Yes. What to do? Okay. So now let me see questions. Questions I've checked in the chat room. People are dropping off before asking questions. Why? Any hand up? Okay. Maybe the questions will be next time. Yes, Paddy?
No, nothing. I have no question, doctor. Thank you so much for persisting.
Okay.
And
Yes. Now, on Monday, we should be able to finish. So please let everybody come on so that if there are any, but I know last time some people complained about their data. Now, this time on Monday, please, you put what they call work from home so that you have enough
Doctor,
data
there's a
and we
question
can
in
have
the
enough
chat.
questions. Yes.
There's a question
There's
in
a
the chat,
question. Okay,
doctor.
let me check. Okay, let me check that. Let me check the question. Oh, the geographical tongue, yes. Geographical tongue, yes. I said the geographical tongue happens to be fairly common. It presents with, like a grooves on the dorsum of the tongue, and the exact cause may not be very clear, but sometimes maybe it can be associated with nutritional deficiencies and so on and so on. Maybe some vitamin deficiencies. And I'd asked that because I know it's a problem which can persist, it is fond of recurring. I was requesting that you guys read about it. So if there are any questions, you can ask me when we meet on Monday, because it is something in clinical practice we are going to meet a lot. And if you don't help the patient will continue to feel miserable. Yeah. But sometimes just simple knowing what may be causing it from, again, doing history, good history may help you, because sometimes it can be, you can find that it is associated with other conditions, maybe iron deficiency, maybe some vitamin deficiency. And so maybe just improving that, you find that the patient is really responding. Yeah. So please read about it. And then Monday, if there are any that said, and oh, Twitter. Okay, no, I have Twitter handle, but I don't use my Twitter very frequently. Maybe my email. Paddy has my email. Paddy, you can give them my email. Is that okay, Paddy?
yes, it's
Paddy. Hey, yeah, you can. Yeah, good. Yeah. So I wish all of you a blessed evening. Yeah, I wish you a great week.